Titicaca, but the other side, not the Bolivian side.
Oh yeah?
Um, but when we were on the Uros Islands, and the
Mm.
owner told us if anyone cuts the ropes of the islands, we will wake up in Bolivia.
Oh,
But we didn't wake up in Bolivia.
we are going to YouTube, few seconds, and we are online, I think so. These things with internet
Bolivia.
let you nervous. And you've been right because sometimes you have problems during the connections, everything. Okay, Marie Claire, thank you for coming. Please give me the time for do your presentation. I hope my English you can understand. I will talk in Spanish a little
Sure.
bit. Thank you. Buenos días a todos. Gracias por estar presente en una sesión más de nuestro sistema de educación por online desde Bolivia, Santa Cruz, Bolivia y el Hospital Japonés. En esta oportunidad, it's an honor for us to have the famous Dr. Mary Claire Farrugia. She is a consultant pediatric urologist in London, and we are so proud to have her with us. So, Mary Claire, thank you for accepting. You didn't know me, but the first time I be in touch with you, you told me yes, and we appreciate too much this. Thank you for being with us, and you are on command for your talk. Thank you.
And thank you to everyone who joined us today. I, of course, said yes. I love South America. I love being there, and I'll take any opportunity to be able to share some time with everyone. So thank you for your time. Yes, so I'm a fetal and pediatric urologist in West London. Fetal urology is one of my big passions, and I run prenatal counseling clinics in two major hospitals in West London. So I've seen hundreds of scans, seen hundreds of families, and fetal intervention is one of the big questions that often comes up. So I've looked into it quite a lot, as you can see. So today I will start by explaining the pathophysiology of lower urinary tract obstruction, or Luto for short, and the current outcomes without intervention. I think to know whether intervention is going to make a difference, we need to be aware of what to compare with, i.e., what the outcomes are without intervention. We'll go through fetal intervention so far, and then the new directions and new challenges. So Luto happens in about 2.2 per 10,000 births. And depending on what study you read, only 30 to 60% are actually diagnosed prenatally. So what this means is that a significant number of these patients make it to birth, they have a good perinatal survival, they actually escape our radar and then present late. The typical prenatal findings are what you can see in this fetal image. It's a bilateral hydronephrosis or hydroureteronephrosis with a very distended bladder. And sometimes we can also see the dilated posterior urethra. And this is what is typical of what we call a keyhole sign. Now, you need to be aware that even with all of these typical features, even in the presence of oligohydramnios, the diagnosis is Luto in only about 53% of cases. So, fetal ultrasound, although it's becoming more and more accurate, isn't that sensitive in giving us the correct diagnosis. It is also important to remember that the fetal metanephros will only start functioning at about 12 weeks. And therefore, amniotic fluid doesn't constitute fetal urine until about 16 weeks. So when we see a megacystis early on in pregnancy, so in the first 12 weeks, it doesn't necessarily mean that we are dealing with fetal bladder outlet obstruction. In fact, these very good prospective studies from the Netherlands have shown that up to 20% of fetal megacystis in the first trimester will resolve spontaneously. And of the ones that persist, only some of those patients will turn out to have bladder outlet obstruction. Up to a third of them will have chromosomal or other anomalies, such as cloacas, and 14% will be normal. So when we see early megacystis, it might be too early to take a decision then to decide that we may need to intervene prenatally. Now, all the outcome studies that we look into regarding fetal intervention are
Bien,
based on a diagnosis of
en
posterior
serio,
urethral valves.
por
And there are no outcome studies on intervention for other
qué
diagnoses,
hacen Cracovia.
which
Oye,
we
bien.
know
Doctor,
are.
excuse me, Mary Claire. Doctor Hugo Arza, por favor, su micrófono, apáguelo.
So we know that there are many causes of fetal bladder outlet obstruction, although posterior urethral valves are the most common. Now, even if we have posterior urethral valves diagnosed prenatally, the outcome can be very variable. And we know this from our patients with valves. You could have a valve patient that goes through childhood like nothing happened, and another valve patient that's struggling all their life with renal and bladder dysfunction. Now, there are various studies on fetal models of bladder outlet obstruction, in particular the fetal lamb model, which is what I studied when I was doing my research. And these are some pictures from that model, which show us that even prenatally, the typical picture of bladder and renal dysfunction can vary from one case to the other. So even if you obstruct the fetal urethra to exactly the same level in every fetus, the outcome will be different. You can have a completely normal kidney development and only mild bladder changes. You can have very big distended bladders or small, very thick walled bladders. We can have some moderate renal dysplasia, or you can have very fibrotic kidneys with big glomerular cysts. And this is apparent in the fetal lamb model, and we know this happens in real life. What about the long-term outcomes of posterior urethral valves? So the most famous long-term outcome study is the one by Helen Parkhouse, which is quite old now, from the 80s. But this is when the first figures of 30% go into renal failure came from. Since then, we have had more recent long-term outcome studies. The second study is from Leeds in the UK. The third study is a combination of French and Egyptian patients. And we might be seeing a slight drop in the incidence of long-term renal failure of between 17 and 22%. However, what we must be aware of, that incidence of end-stage renal failure comes on gradually and usually doesn't come on in the first few years. It is therefore very important when we're looking at outcome studies of fetal intervention to make sure there is a long enough follow-up so we can compare the incidence of renal failure appropriately. This is the BAPSCAS study from the UK. Again, it's an audit of patients with posterior urethral valves. The key information I want you to focus on here is that, again, the most common diagnosis is posterior urethral valves with an incidence of urethral atresia that's only 3%. It's quite rare. And this will become important when I continue my talk later today. The other thing to bear in mind is that although we are aware that some patients with oligohydramnios will be born with pulmonary hypertension, the perinatal mortality isn't actually very high nowadays, and in this study was less than 1%. This is a bigger study from a US national database, 685 patients with bladder outlet obstruction, followed up for up to 14 years. Again, the survival isn't as bad as we think. So the survival was 98% at 1 month, 95% at 1 year. And in the first 10 years of life, up to 10% went into end-stage renal failure. It is also important to notice that this and other studies have shown that prematurity is a disadvantage in babies with posterior urethral valves, and it will triple the mortality rate. Therefore, it is not an advantage for these patients to either be delivered early or to suffer a risk of prematurity. So now that we have this background information, what do we want to achieve if we were to be successful with in utero intervention? We want to intervene on the right patient, so it's really important to try and get as close to the correct diagnosis as possible. Clearly, we don't want to intervene on normal patients, neither do we want to intervene on patients who have chromosomal anomalies or other abnormalities which will not benefit. We want to try and do better than the 1 to 5% mortality in the first year. We want to do better than the 10% incidence of end-stage renal failure in the first 10 years. And ideally, we want to do better than a quarter of them going into end-stage renal failure long term. We also, if possible, want to try and avoid prematurity. So how do we do this? We know, and it is well established, that by restoring the amniotic fluid volume where you have oligohydramnios, we can prevent pulmonary hypoplasia and improve perinatal survival. And that is pretty well established. What we don't know is whether we're making any difference to the long-term renal function. So where are we at the moment? What have we achieved so far? You are all aware that the commonest technique of in utero intervention is vesicoamniotic shunting. It's done via a fetoscope. And most centers are still using the shunts developed in the 80s, which are the Harrison and Rocket shunts. They work, but there's a big external component, so the fetus can very easily pull it out. They often get dislodged, they can get blocked, and they often need to be replaced. Most of you will be aware of the Luto trial, which is 12 years old now, but it was the most important randomized controlled trial of VAS versus conservative management at the time. The problem with the study is that there was no patient selection. It was a very vague patient selection. It was difficult to recruit patients. And the only real conclusion we have is what we probably knew already, that it can improve perinatal survival. The follow-up was only 2 years, and at 2 years, there was no difference in renal function. It also highlighted the problems with the shunts at the time. And as I said, they tend to dislodge, they tend to cause problems. There's in utero deaths and fetal demise, essentially. So 4 of the 15 pregnancies were lost. Some very specialized centers have been performing fetal cystoscopy. This is also done via a fetoscope, which is a straight instrument. There's no specialized instrument to do this. It's technically very demanding, but the advantage is that we can see what the diagnosis is. So that's the beauty of this technique, that they can see whether there's an actual obstruction and what the obstruction is or not. And if there is an obstruction, then it can be either laser ablated or if it's a stenosis, stented. Another advantage is that the bladder isn't decompressed by foreign material for the whole of the pregnancy, so the bladder can be cycled. But again, it's a very limited procedure. There haven't been any recent outcome studies that I could find. These studies are now quite old. The top one is a multi-center study in the US, which was relatively promising. They suggested that at 6 months, again, short follow-up, there was possibly an improvement in renal function benefit. But there was a high incidence of complications in particular fistulas, because like I said, the instrument is straight. It's very difficult to get it in the right position. And sometimes the anus was being lasered, skin was being lasered, and there was a risk of fistulas. There was a more sobering outcome study from a French center. High complication rate, high chronic kidney disease rate, high technical failure rate with premature labor, evisceration, perianal fistulas, and bowel perforation. So this is not an easy procedure. And this was a fetal meta-analysis covering all procedures, which again suggested that maybe there may be an improvement in fetal renal function, in postnatal renal function. But again, the show follow-up was very short, and we don't know what's happened since. So in one of the Society for Fetal Urology meetings we've had in the last few years, there was a big debate going through the literature on what are the next steps to try and maybe harmonize what we do, how we do it, and when we do it. And we had established 5 steps that may lead us to a better collaboration in fetal intervention. The first one was we need to improve our diagnostic accuracy. As I said, unfortunately, it's very difficult to diagnose posterior valves prenatally. Various authors have suggested clinical scoring to improve the diagnostic accuracy. Probably the best way forward is fetal MRI, especially 3D MRI, which is becoming more accurate in showing us the diagnosis. And surely where we are considering a high-risk intervention, it is probably worthwhile having a 3D fetal MRI. Rodrigo Ruano established this staging system of fetal bladder outlet obstruction into 4 stages. Stage 1 is the good picture, where you have well-developed kidneys, no signs of established fetal renal failure with normal amniotic fluid. And these babies tend to do well. They certainly do not need fetal intervention. The stage in them progresses to stage 3 and 4, where you have signs of established fetal renal failure. So this would include renal echogenicity, the presence of features of fetal renal dysplasia, such as cortical cysts or small kidneys, oligoanhydramnios, and in centers which perform fetal urine evaluations, then you have signs of fetal renal failure. Some centers will still offer intervention in these stages, but it must be warned that all we're doing here is probably preventing pulmonary hypoplasia, which may mean that you get an improved perinatal survival, but at the expense of a potential preterm baby, probably already an established renal failure. So this will need very thorough counseling, and we need to be sure that there's the support system and the ability of neonatal renal failure management in the center where they are delivered, which isn't always the case, unfortunately. Then there's a middle group, the stage 2s, where you might have echogenic kidneys but not established fetal renal failure. So there aren't established cortical cysts. The kidneys still look like they have a decent cortex. Your amniotic fluid is either dropping or maybe at oligohydramnios, but not anhydramnios. And if you manage to catch this at an early stage, then this may be a group of patients who could benefit from fetal intervention. It would be really helpful to find ways of establishing whether the baby's going to have pulmonary hypoplasia, whether the baby's going to develop renal failure. Now, we know from various studies that oligohydramnios before 20 weeks is very highly suggestive that the baby's going to have pulmonary hypoplasia and is at risk of neonatal demise, essentially. As we've already said, fetal ultrasound isn't very accurate in establishing fetal renal function. So even the presence of echogenicity and cortical cysts doesn't necessarily mean that the baby's going to have postnatal renal failure. There are some good quality studies suggesting that fetal blood and urine beta-2 microglobulin can be predictive of fetal renal function. There is also a current ongoing multi-center study called the antenatal study based on proteomics in the fetal urine. And I think this is very exciting. It should hopefully conclude this year, and it might be the best bet we have in trying to predict fetal renal function. So we're looking forward to those results. This is a slide borrowed from Craig Peters that I think many of us used to teach. And it essentially shows you the fetal kidney development and the fetal lung development. Now, as I said in the beginning, the fetal metanephros will start to function at about 12, 13 weeks, will become well established at 16 weeks, which is why probably intervening around this window may make sense in order to try and avoid the superimposed obstructive damage that happens to the kidney. In terms of the lung, it's important to try and intervene before the canalicular phase, which concludes at 26 weeks. So definitely intervention after 26 weeks is not helpful for anything, lung or kidney. Before 26 weeks, we may make a difference to the lung development. Lastly, we need innovation. We need innovation in shunt technology. We need innovation in fetal cystoscopy. So we need better shunts, which are harder to pull out, harder to displace, ideally that don't leave the bladder decompressed for all of pregnancy. And we also ideally need a fetal shunt that is able to be, a fetal cystoscope that's be able to be angulated, so you get less risk when using laser. So are any of these new directions happening? And yes, they are. We do have a new fetal shunt, which is the Somatex fetal shunt. This is already being used clinically. Its advantage is that it's quite easy to deploy. It's like an umbrella. It also doesn't have an external component, so the fetus can't pull it out. And it forms this sort of mini vesicostomy once the fetus is born. The disadvantage is that if the fetus can't remove it, then probably adult people can't remove it, and it's very difficult to remove postnatally. It's also quite wiry, and there's reports of damage to other parts of the fetus as it's being deployed. This one's very interesting. It's still in the animal model phase. It's also quite flat, so it will be harder for the fetus to pull out. And what's interesting about it is that it's got a one-way valve. So it's designed to decompress the bladder only when it's distended, and it won't leave it completely empty. So if this one works in animal models, it would be quite helpful to have in human fetuses. There are a couple of centers in Cologne in Germany which have already been using the Somatex shunt clinically, and there are a number of published outcome studies. They've been using it quite early, before 17 weeks. This is a study comparing the Somatex shunt before 17 weeks with the Harrison shunt. And their initial study of 24 versus 33 patient showed that there seems to be a better survival rate with the Somatex, a reduced dislocation rate of the shunt, and at short-term follow-up, there was a better renal function with the Somatex shunt. However, the renal functional outcome was only 87%. And remember when I showed you in the beginning, our outcomes are better than that without shunting. So I'm still not sure this is the way to go, but it's probably a better shunt. On the other hand, what was interesting about this outcome study is that there was such a high incidence of urethral atresia and stenosis. Again, remember in the beginning when I showed you the outcome studies from the BABCAS study, there was only 3% incidence of urethral atresia. And this study said they had 41% urethral atresia. And that started to raise alarm bells. This is another study from the same group of 46 fetuses shunted with the Somatex shunt. They went even earlier in this group of patients. So they compared shunting at 14 weeks with 14 to 17 weeks and after 17 weeks. Again, as I said in the beginning, it's very difficult to make the right diagnosis the earlier you go. So 10% of their patients were female. They had a high incidence of other diagnoses with cloacas, chromosomal abnormalities, and factor. Quite a low survival, 74%, compared to our 95 and 98% without intervention, and a high prematurity rate. So we do need to be really careful when advising shunting so early on. This publication concluded that because there was a 90% of newborns with sufficient kidney function, that we should be shunting everybody this early. But I would be cautious making such big conclusions. So what are our challenges now? Well, okay, we've got a new shunt, but it's very difficult to remove. So about 60% of patients will need a GA to remove the Somatex shunt, and it was found to be embedded in bowel, abdominal wall, and bladder, so quite difficult to remove. It's also very odd and strange that we're getting so many more urethral abnormalities. And this recent publication showed that there was a high incidence of urethral atresia, hypoplasia, urethral duplications, and very unusual urethral abnormalities. And it is suspected that it's because the bladder was left decompressed for pretty much most of the pregnancy and the urethra didn't get a chance to develop. And the problem with having urethral atresia and hypoplasia, that those of us who've seen it know it's even harder than posterior urethral valves to manage. And some of them will go into renal failure quite early on. Therefore, in conclusion, unfortunately, no conclusions can be made until there's a randomized controlled trial, including intervention and no intervention with a long enough follow-up. There's some promising new shunt technology evolving, but it's not yet good enough. We need to do better. It would be really exciting if there was new fetal cystoscopy technology. I think that might be a way forward. It was interesting and very brave to see that intervention below 17 weeks is feasible, but are we shunting an unnecessarily high proportion of fetuses who don't need intervention? There's an increased risk of prematurity. Are the renal outcome rates any better than what we have already? And are we producing new urethral pathologies? And some learning points from today's talk for those of you who do prenatal counseling. Oligohydramnios before 20 weeks is probably a poor outcome. They will have pulmonary hypoplasia. These fetuses, if you do nothing, usually will make it to term. And I often get asked, is it worth delivering these babies early? And I don't think it is, because you want the glomeruli to develop as far as they can go. So I would get these babies as close to term as possible. In fact, the American study has shown us that prematurity increases mortality threefold. Survival without intervention isn't bad, and we need to do better than this if we're going to intervene. And end-stage renal failure in the first decade is only 10%. So with any plan for in utero intervention, we need to consider the timing. Before 26 weeks is better, but I'm not sure the earlier the better. We need to really find the correct window and try and avoid babies with established signs of fetal renal failure. And definitely an honest and thorough counseling with the parents is really important, ideally in the MDT setting with pediatric urology and nephrology present. And thank you to you all. Thank you to all my friends in South America. I look forward to seeing you hopefully next year.
Thank you very much, dear Marie-Claire, for your amazing talk.
Thank you. I'll try
And
and stop
we are
sharing.
waiting for answer for questions. But I have one. Please, could you tell me which should be the expectation you have about the Vortex device in these cases?
I mean, it could be a good one. I've seen a couple of, there's a couple of publications on an animal model, which seems to be working well in the sense that it's less like it works. It's easy to be deployed. It's less likely to be pulled out and dislocated by the fetus. I haven't seen any studies on the fact that it's a one-way valve, which I'm looking forward to because I think we need a device that doesn't keep the bladder decompressed and the urethra dry throughout gestation. So I think if the one-way valve works, then we might feel a bit happier about using it a little bit early on. I think 12 to 16 weeks is too early. We'll be shunting a lot of normal fetuses where the megacystis might get better anyway. But maybe the 16, 17, 18 week window might be right if we manage to keep the bladder partially decompressed and not completely dry. So yeah, I don't know if there's anyone in the audience who's been involved with this, but it would be an interesting shunt if it works.
Oh, thank you. We are waiting for questions, but I have another one. Do you it's very difficult, the catheterization, the antegrade catheterization, catheterization of the fetus, because I've been thinking you do the vesical amniotic by function, the bladder, but to catheterize the urethra is very difficult, it's impossible.
Yeah, I mean, I don't do it myself, and I'm not aware it's done in the UK at all. But when I visited Cincinnati, and you had a talk last month from Cincinnati, they seem to do it. It's not easy at all, so they do it via fetal cystoscopy. So you need to be able to see the urethra and then insert a very, I'm guessing a 3 French or a very small JJ stent. I can't imagine it's easy to do. And it will still probably decompress the bladder, so you may as well just shunt it. Um, but that's the problem with fetal cystoscopy using a fetoscope, that it's very, very technically demanding. And the interventions have a high complication rate. So we need new technology there as well, ideally.
We have from ja, Jafrul Haran. He asked, should we say that fetal intervention is still under evaluation or it can be therapeutic?
Still under evaluation. I think I think all these studies put together, like I did today, may help us get a sense of whom it might benefit. But the patient selection needs to be really, really good. And I think we need to think of those 5 criteria. Just, is our diagnosis right? Is the window right? Is this baby going to benefit? I.e., we don't want we don't want to just improve perinatal survival, because we don't want to have a premature baby and renal failure. I don't think that's going to benefit anybody. But is there a chance that we give this baby a perinatal survival with a decent renal function? So we really need to consider all of these parameters, which is why I think an MDT setting and a real case by case selection is important, rather than just blindly chanting all the megacystis or all the oligohydramnios. It really doesn't make sense that way.
Thank you. My friend from Chile, Guillermo, asks you, your talk is excellent. Thank you very much. With the advance of uterus surgery, if you observe in spina bifida, it's possible to access the bladder directly and to put inside the urethra the catheter. So the question I did, but in neurogenic bladder.
I'm not sure I understood the question. So is the question whether we can catheterize the bladder?
The you
I mean, I think that's what they're trying to do antegradely, to do it retrogradely, you mean?
yeah.
Uh, I think that's going to be really difficult early on. I mean, it's different if you try to do it in the 3rd trimester, which is too late anyway, but I can't imagine trying to catheterize a 18-week fetus. But who knows? Yeah.
I have to translate the questions. Respect Ruano classification stage 2. The values, sorry, of reference and the markers you have in urine define the deterioration of the renal function in different ages, fetal ages. Did you understand?
No.
And the question is, if there is differences in markers,
Oh, I see.
in urinary markers, if you have in different
Different
ages,
stages.
the fetal age.
Good question. I do not know. I think a lot of the literature just gives like a spectrum, and I'm not aware that I've read that there are any publications about different gestations. But the other thing is that this new proteomics, the antenatal study with proteomics, might be the next best step. There's a lot of new things happening, which I think maybe in a year my talk will be different. And I think if the proteomics study comes up with a good estimation of fetal renal function. I think that might be the best step, and it would be more accurate than the beta 2 microglobulin what we have so far. But another point about the stage 2, I've tried to look for stage 2, and it's not easy because depends when you first see those patients. So usually they'll have an anomaly scan and then they get sent to our tertiary center, for example. So by the time I see them, they're already whatever 20 weeks. Um, and then if I see a patient who's maybe got normal or low normal amniotic fluid, echogenic kidneys, but not established renal failure, then I try and monitor them closely. And if I see a drop in amniotic fluid, then that might be a good window for intervention. But they're not easy to find and they're very rare um, to catch them. So although stage 2 on paper sounds like a good idea, you need to be able to get them at the right gestation and also monitor them quite closely to see that they're at a stage 2.
Thank you. Any question? There is no question. PJ, they say, great talk. Thank you very much, Mary Claire. And Dr. Leopoldo Torres from Mexico say, amazing presentation. Thank you
Oh,
very
it's
much.
very kind.
So, people, we are so grateful with Marie Claire. Please let me tell you your name only, and maybe the next time you can be in Bolivia with us, making
I
some.
would love to.
Thank you very much for
Thank
your
you for having me.
patience and to be so kind with us, for being here with us. Okay,
Bye, everybody.
bye. Gracias a todos. Disculpen el inglés porque traducir, pensar es muy difícil a veces para mí. El próximo mes lo tenemos al doctor Juan Moldes. Por favor, anótense. La fecha está para marzo, con cirugía con compasión. Es lo que los cirujanos piensan actualmente. ¿Ok? Gracias a todos por su presencia y nos vemos el próximo mes. Mary Claire, thank you very much.
No problem. Bye, everyone.
Bye bye.